Okay, and we're live. Hello everyone, welcome to the webinar on suicide prevention arranged by SCOPH. This was a collaboration between the European region and the Americas region, because this year we have mental health as a priority for those regions. We have our two RAs, Maciek, the RA SCOPH for Europe, and Juanse, the RA SCOPH for EMR. Sorry, for the Americas, who've been working very hard for this webinar and even generally as regional priority in mental health. Now I'm going to completely hand over the webinar to them both to go over their agenda and to introduce the speakers, etc.
Okay. Hello, everyone. I'm Maciej Gajski. I'm SCOPH Regional Assistant for Europe. And well, I leave the floor to Juanse to also introduce himself.
Okay, hello everybody. My name is Juan Sebastián Valderrama. I'm the current SCOPH Regional Assistant for the Americas, and we are really pleased to have this webinar today with you.
Okay. So we'll start first to show you our agenda for this meeting, and I would like to ask to change the slide. Okay. So today we are going to talk about suicide and how to prevent suicide in general. And what is first, our point of agenda is what is the public health perspective of suicide. Then we will welcome some external speakers. Firstly, it's going to be the Dr. Israel Gonzalez. After that, we'll have the IFMSA program coordinator on mental health. And then we'll proceed to the project made by Belgian Medical Students Association called Start to Talk. So that's our brief agenda for this meeting. Okay, I would like to ask to change the slide. So okay. At the beginning, we'll start with some very short story about the person who's struggling with suicidal thoughts. And just to outline the personal perspective of suicide. So I'll start. I've struggled with depression as long as I can remember in my adult life. It has followed me everywhere I've gone, like a big heavy black gate dragging behind me. Up until 18, I was fine, but that's when I started hiding away from people. It's when my alcoholism started, and it's at the point I started to just not feel comfortable around people. 16 and a half years later, I'm still fighting the same fight. Day in, day out. It's led me to severe alcohol addictions, losing friends, and suicide attempts. After all that, do I feel better? Well, not yet. I still struggle to explain this, and I struggle to let family and friends in. Sometimes my working day feels like it's 2 days long. I limp through that, and then I struggle with being on my own, fighting my mind, fighting anxiety, fighting alcohol dependencies, and just fighting to simply stay alive. I hate it. Suicide, it's a normal thought for me, and it's one I suppress, at least once a week, but often more. I've never seen myself getting past the age of 35. My 35th birthday is 4 months away. The nearer it gets, the more hope I have that once I get through it, it will all stop. But I have to be honest, I cannot guarantee that I will get through it at all. I can't see myself living past 35. It all goes black. So, with this simple short story of persons facing suicidal thoughts, we would like to ask you, like, who is the person who's facing the suicidal thoughts? Is it the end stage of depression, or it's multidimensional factors that lead to depression? We would like to ask you to leave the comments in the webinar on the YouTube to tell us what do you think about this story, and what are your first initial thoughts? And Juanse, would you like to also ask participants where they're coming from?
Yeah, sure. just because we want to make of this webinar really interactive event, and not only maybe just to listen to speakers, we want to listen to maybe to our participants, want to know like where do you come from, like your name and your country, so that we can just like get to know like where our participants are coming from. You can just write in the comments below on YouTube, and we are going to read them out so that we can just like get to know it. Okay.
Okay, so we'll be waiting for your comments in the webinar to make it a little bit more interactive. Tell us from which country are you, from which animal, what you are doing animal, if you are interested in the topic of suicide prevention, and what do you think about the person who is struggling with suicidal thoughts, the situation that we described recently here.
Exactly. The idea is that you guys can just interact between each other, and you can just like say maybe, I don't know, what you think, your comments, your opinions on the things that we are going to be saying over here. Okay, so now just we are going to be just reading you through the whole webinar. So next slide, please. Okay, so we want to start this webinar by asking, or at least answering to the question, why is suicide a public health concern? Is it actually a public health concern? Is it a public health issue? Well, that's what we want to answer today in order to see if this webinar is actually worth it or not. So that's why, could you please change the slide? We have brought some statistics from the WHO, and it's estimated that about 800,000 people die because of suicide every single year. So I don't know if you think that this number is alarming, but for me, at least, it is a huge number, and it is a lot of people dying because of suicide every single year. But I don't know if it is not alarming. Well, that actually is not all, because can you change the slide, please? We have for every single person who dies because of suicide. Can we change the slide, please? By every single person who dies by suicide, there are going to be 20 people who will attempt to suicide in the future. So it is really, really alarming, because here you're gonna see that it is about 10,000 million people attempting suicide every single year. So if you don't think that this is actually a huge number, then you have to see the next slide, please. In which it is not only, it doesn't affect just the people who attempt suicide or who take away their lives of suicide, but also it affects family, communities, and the entire countries. It affects actually the whole people that are surrounding the person who commits suicide. So that is why it is really important to understand that this is a problem that involves many people in our societies. And sometimes we don't actually think that it is important, but you can see that even more than 10,000 million people are actually suffering from suicide and all the morbidities that this actually also carries. Next slide. However, if we like start thinking about this, of course, those are really big numbers regarding suicide, and those are like big numbers in every single region. However, we have good news. Next, please. And we know that suicide, it's something that can be prevented, you know. So that is why like we are here. That is why we are just like having this webinar in order to raise awareness among our members, among medical students, among health professionals, because we know that there's something to do, you know, regarding suicide. There's actions to be taken, and we know that we have the abilities to do it. However, I think that the first step to do it is to raise awareness about these numbers, because like most of the times we just see these numbers and we say, okay, 800,000 people is dying because of suicide, but we don't really believe it. So the question here is not if suicide is a public health problem, but it is the question is, do you believe that suicide is a public health problem? Well, that's maybe up to you. So Yeah, I think that that's been for that for the introduction. I think we can go to the next slide, please. Okay, so and now I would like to ask to the participants, um, who do you think is at risk of committing suicide or attempting suicide? We are going to be reading your comments below.
For those who do not have the channel, like account on YouTube, you can also leave the comments under the post in the Facebook event. I'll just put the question in the webinar, in the event on
Exactly.
Facebook, okay?
Exactly. So we are here glad to hear Sabri from Turkey. She's an LPO from her NMO. We have another person from Turkey. She's doing great, she says. We have Daniela Lopez from Asimcol. Thank you very much for being here. Thank you very much to Gregory from Greece. Thank you very much. Okay, so well, we don't have answers yet about who would be at risk, but we are going to well follow with the webinar. Okay, so now who is at risk? Here we're going to find that there are two risks or two big groups of risk in this case. You can please follow the webinar. Follow to the next slide, please. Okay, so here you're gonna find that we have two big groups of risk factors. The ones are vulnerabilities, and the other ones is stressful life events. So regarding vulnerabilities, it's just like those people who are in some condition that they cannot change, or that it is hard for them to change it. So, for example, you're going to see that people who are refugees, migrants, who belong to LGBT communities, it is really common that people who commit suicide, they suffer from mental health disorders. It is like about 90% of the people who commit suicide, they have a mental health disorder. Not all of them like commit suicide. Also, we're going to see that ethnicity is also a risk factor, and we believe that the strongest risk factor for committing suicide is to have a previous suicide attempt, because the statistics say that 50% of the people who attempt suicide are going to commit suicide and take away their lives in the future. So it is really a strong risk factor that we need to take into account. Also, you're going to find here the stressful life events that can maybe happen to anybody. We have bullying, people, for example, who have parents separation, for example, people who love pets, who love maybe a dog or a cat. It is hard for them to maybe to go through those moments. Also, people who are sexually abused or physically abused, it is also very important to take it into account. And finally, something that is very common among medical students is to have academic difficulties. So it is really something that maybe it is really interesting to realize that we all, as medical students, are like in risk to suicide. So the question here is that I know that we as medical students, at some point of our careers, we know about these risk factors. We know that this can happen. We know that, okay, because we have maybe we have had a class regarding this. However, like the real question is, are we these risk factors into our daily lives? It means, are we actually relating these risk factors to our partners? Are we able to recognize these risk factors? And even more important, are we able to approach the person in which we recognize that is having a risk factor? Well, that's something that maybe we need to take into account. So next slide, please.
Okay, so now let's talk about the methods of suicide. And initially here, you may wonder, why do we even talk about the methods of suicide? Is it actually really important? So as a matter of fact, it is very important, because if we do have accurate information about preferred suicide methods in our own countries, we can create the strategies and programs for effective suicide prevention. if we restrict the access to the means of suicide, we may actually reach more comprehensive strategies. Studies have shown that many suicidal attempts are very impulsive, are very, let's say, out of blue. Thus, if we do increase the access to very common and easy way to commit suicide, we may give the person time to rethink it, and thereby we can prevent it. So in the world, globally, 30% of suicides are due to pesticides self-poisoning, most of which occur in rural agricultural areas in low and middle income countries. Other common methods of suicide are hanging and firearms. With this data, we have to take this data very carefully, because a large number of people live in Asia and Pacific, and that's why statistics shows that pesticides are the most common way of suicide. Anyway, so we can see here that it differs among different countries. If we speak about Europe, the most common method of suicide is hanging. Mostly in the East Europe, it's as a predominant pattern. If we speak about the South America, one of the most common method is firearm, so using basically the gunshots. Another method of suicide is also jumping from the height, and it's particularly important in very urban societies. So you can imagine it's, for example, very common in Hong Kong or like Luxembourg or Malta. And as we said, as Juanse said, suicide is preventable. So why, for example, we need to know why it's so important to know what's the method of suicide. For example, if in our country the hanging is the most like common method of suicide, we have to know what it comes with it. So hanging as a method of suicide is very violent. It needs some preparation. It needs some degree of courage and determination, right? For example, if the most predominant pattern in our countries is, for example, jumping from the height, we may think about making, for example, that space, like we may think about restricting access to the high buildings or making some kind of a barriers for people who may consider jumping from the height. Okay, can we change the slide, please? So now I would like to talk a little bit more about the evidence-based suicide prevention programs. So as you can imagine, suicide is very important in terms of public health perspective, because as we mentioned in the description of the webinar, it's the second thing that kills young people in Europe, just after, not only in Europe, sorry, also in the world, just after car accidents. Anyway, we do not have very strong evidence what kind of prevention methods are effective because it's very hard to evaluate it. We can divide basically the suicide prevention methods into three different ways. The first one is the universal, so the kind of the prevention policies that are addressed to general society. The second one is the selective. So we give some kind of a more attention to people who are at the higher risk, as the Juanse mentioned, for example. And the third one, the type of the prevention measure, is individual. So especially to the people who already have some suicidal thoughts, or you already attempt suicide in the past. So I would like to give you some examples of the suicide prevention methods that works, that have some kind of a level of evidence, of course limited, but showed the positive effect in the countries among the world. So the first one is to restrict the access for the means of the suicide. And as an example, I will give you the policy from United Kingdom. So basically what they come up with is that they restrict the pack sizes of paracetamol and salicylates on self-poisoning, right? So let's say that in UK, taking those drugs, over-the-counter drugs that are quite accessible, is what kills people. What is considered as a method of suicide. And actually, when they reduced the number of the tablets per package from 32 tablets to 16, there was a significant reduce in the incidence of deliberate self-poisoning. So you can see that restriction of the access to the suicide means is actually very effective. Another example is the releasing the medial guidelines from Vienna, Austria. So maybe you are familiar with it, but there is some kind of a phenomenon called a copycat effect. So in the past, when media showed, for example, that somebody made a suicide, committed suicide, the media usually kind of sensationalized this and glorified the person who committed the suicide. And the people who were facing the suicide thoughts were more likely to encourage. And at this point, I have to outline that it's just the way the information was presented. So it's once again, I want to underline that it's a myth that talking about suicide is actually the encouragement, but it's very important how we communicate the suicide. Like it's very important how we approach the problem, as it's very sensitive. So when they released the guidelines in Austria, how we should present the data of suicide, how we should talk about the people who committed the suicide, and actually they were more extreme because they completely forbidden the presenting the suicide cases in their television. There was a very significant and very immediate drop in the suicide attempts and suicide which were succeeded. Okay, another means of another suicide prevention method is early identification, treatment, and care. And at this point, it was studied that if we educate the general practitioners how to recognize people facing the suicide thoughts, and who are the people that might be at the increased risk of suicide, there was actually very good impact of this training of the general practitioners. Actually, it has been evaluated that the people who were either committed suicide or attempted had a contact with their general practitioner at least 1 month before the suicidal attempt. So we see that the person, the general practitioner, might be the very good gatekeeper for the people who may face suicide. We should be very careful about the people who say that they are depressed, and always seek for assess if there is if there are some suicidal thoughts associated with it. So another successful suicide prevention method is the follow-up care for the people who attempted suicide. And it's very logic that we should care about the people who already made some first attempts, because it's an obvious sign that they are facing the suicidal thoughts. Okay, can we change the slide? Okay.
Okay. Thank you very much, Pashik. So now we are going to have our first external, who is Dr. Israel Gonzalez. Dr. Israel Gonzalez is a current resident at the psychiatry department in Hospital de Clínica. He's a fellow researcher at the neuroscience department, Hospital de Clínica, and also he's a postgraduate in mental health and for psychiatry. So we are really pleased to have you here, and really well, looking forward to hear your experience and your knowledge about this. Welcome.
Sorry,
thank
you. Can you? Yeah, thank you very much, Juan Sebastian, for inviting me. It's an honor to be here. So what I wanted to focus on this my part of the webinar was physician burnout and suicide prevention in this specific population. I mean, if we can turn on the PowerPoint presentation. Yeah, thank you. So on the next slide, we're gonna see that the med school experience, like what we go through, is a very stressful and challenging experience, which make us vulnerable to depression, anxiety, and burnout. And that doesn't really stop in med school. I mean, life after med school is still full of chronic stress. I mean, you deal with patients every day, crazy bosses. So in the system puts you under a lot of pressure. And how we deal with that, stress is determined by our capacity to cope with that stress, and that really varies between individuals. I mean, there are people who can go through extreme levels of stress and don't get depression, they don't get anxiety, but many of them do, and many of us do. And so if we look at the next slide, we're going to see how stress happens in medical students. And stress is really the sum of a very, very demanding work and a very type A personality that I think characterizes most of us physicians. I mean, we're obsessive. We always try to be the best. We always try to provide the best possible care to our patients. And not only in an altruistic way, but also in a narcissistic way, that we need to be best. We need to be better than everyone else, and we want to control everything. And in the context of our work, I mean, there is clearly insufficient rewards in most countries, and the lack of control, that we can't really control the outcomes. I mean, we can do our best, but we can't really make a patient be better, or we can make a patient get better. And so basically, if we are subject to this kind of stress all the time, then that will probably lead to burnout, and that itself will lead to physical and mental impairment. So in next slide, we're gonna read the definition of burnout, which we can define as a state of physical, emotional, and mental exhaustion. It is caused by long-term exposure to demanding work situations, and is a cumulative result of stress. And I think we can all see how easily that can happen in our profession. I mean, stress in medical students and physicians is associated with deficits in medical care, and that is very important, because it's not just us that are at risk when we are burned out, it is also our patients. And there is an apparent lack of recognition of psychological or mental problems when they occur in doctors. I mean, we tend to try to hide it, and sometimes for good reasons. I mean, some schools or some hospitals have policies that prevent doctors with mental disorders from practicing or from doing medicine. So a lot of people or a lot of doctors decide not to share or not to go to consultation with a mental health provider because of the fear of that they will be let go, or that they will not get the residency position that they want to get. So I want to show you a couple of studies. In the next slide, we see a study published in 2014, which is titled "How Does Burnout Affect Physician Productivity?" And the review indicates that globally there is a recognition of the potential impact of physician burnout on productivity. And the majority of studies indicate that there is a negative relationship between burnout and productivity, which is what most of us will expect. And this is where this ties in with our subject today, which is preventing suicide. And it's very logical that a doctor or a medical student who feels burned out will eventually get depressed, and depression is a major risk factor for suicide. And in this study, it was published in 2008, and it's called Burnout and Suicidal Ideation Among U.S. Medical Students. And they showed that approximately 50% of students experience burnout, and 10% of students experience suicidal ideation during medical school. And as Juan Sebastian was saying before, it is important that we believe that. I mean, we sometimes see these numbers, or we throw these numbers around, and we don't really make them ours. I mean, in our experience at our center, in the last year we had two residents who took their lives, and in prior years we had many residents attempting suicide or coming to the consultation room with suicidal ideation. I mean, maybe you can't see it because they don't go to you with their problems, but you have to believe that this is a very, very real problem. And probably some people in your class are feeling depressed and probably thinking about taking their lives. So in the next slide, we see that physician suicide or medical student suicide is preventable. It's one of the biggest or the most prevalent preventable conditions throughout the world and throughout our profession. And next slide, we can see the suicide rates among physicians, and you will probably be able to read that studies on physician suicide collectively show modestly elevated suicide ratios in men and highly elevated suicide ratios in women. In the next slide, we can see that physicians were significantly more likely than non-physicians to have antipsychotics, benzodiazepines, and barbiturates present on toxicology testing, but not antidepressants. So that's kind of it's kind of a paradox that they are willing to take everything. They're taking Ritalin, they're taking antipsychotics to sleep, they're taking benzos to sleep, and they're taking Adderall to perform better. But when it comes to the drugs that will actually help them prevent suicide, they're not using that medication. So in the next slide, we can see a study that basically changed everything, at least in the United States. It was a study published in JAMA, and the title was The Prevalence of Depression, Depressive Symptoms, and Suicidal Ideation Among Medical Students. And the results were surprising because they were so high, and this was a large systematic review with a meta-analysis. So this is not just one study in one school in a very specific area. This is probably reflective of what is really going on in medical schools around the world, and it shows that almost 30% of medical students have depression or at least depressive symptoms, and the 10% of them have suicidal ideation. And in the next slide, this is something that I find like, this is crazy. Neoplastic disease and suicide were the leading causes of death in residents. This was just published last year. And it is data for death by suicide suggests added risk early in residency and during certain months of the academic year. And at the end of the study, Yagmore and his colleagues say that providing trainees with a supportive environment and with medical and mental health services is integral to reducing preventable deaths and fostering a healthy physician workforce. So in light of all this information, I mean, first we have to believe that it's real. I mean, because it is, we have hard evidence that it is. So what can we do about it? So I wanted to share with you 4 steps to prevent physician suicide. They were promoted by Susan Thompson. She is the current chair of the ACP Board of Regents and a professor of medicine at Southern Illinois University in Springfield. So she gave 4 steps that we can take to prevent physician suicide. And the first step, the next slide, is talk about the risk factors and warning signs for suicide and getting rid of the culture of silence. I mean, this is something a lot of physicians and a lot of medical students keep to themselves. I mean, they don't want to be seen as weak. They don't want to be seen as problematic, and we want to always be seen as the ones who will get ahead, who will be better, and who will perform. And admitting that one has a psychiatric illness or that one is feeling depressive, it's sort of like admitting defeat and admitting that you're weak. And we know that's not true. We know that a lot of the depressive symptoms are based in our biology and in our ways to cope and respond with stress, which may be genetic or hereditary. And it is important that we know that. And it's important that physicians know about the risk factors for suicide, as you guys were discussing before, and the warning signs for suicide. I mean, depressive symptoms are probably the most specific symptoms or signs that will make us think that someone is at risk for depression. Someone who is sad most of the day, every day for the last 2 weeks. Someone who's just not wanting to do anything, things that one found joy in before or pleasure in before. They don't like doing that, or they don't want to do them anymore. They're not sleeping well, they're not eating well, they're missing classes, their productivity is dropping, or their grades are dropping. And those are all warning signs that we have to be aware of. In the next slide, the next step is to destigmatize seeking help. We need to portray help-seeking behavior as something brave and courageous, and not as something that a coward or a weak person would do. I mean, it really takes courage in this environment of discrimination and stigmatization. It really takes courage to say, hey, I want to do what's best for me. I want to do what's best for my patients. So I'm seeking help. The next step, and this is more of an institutional step to take, is to make it easy to find confidential help. I mean, physicians and residents and medical students will be a lot more likely to go visit a mental health professional if they know that they can go to a safe environment, that they will not be discriminated for it, that maybe their supervisor is already looking for a way to make their lives miserable, and if they know that they're depressed or that they're having suicidal thoughts, they're gonna go, hey, okay, this is a problematic student. Maybe he should look for a different position. Maybe he should do administrative work. Maybe he shouldn't have this amount of patience. And so, if they can go and seek help without necessarily everyone finding out and talking about them, that would be a big step toward helping residents and physicians looking for help. And the last step is to create a support system for physicians and create a shared responsibility mindset. I mean, we need to start acting as a team, and we need to start looking for signs around us. And it's usually not that hard. I mean, people are usually waiting for you to ask, and they're rarely offended or rarely intimidated or uncomfortable when we ask about their symptoms. So if we see someone whose behavior is changing or whose mood is clearly different from what it was before, it is always good to go and say, hey, I can see that something's odd, something's changed with you, and I'm here to help. I mean, whatever I can do for you. If you need me to contact someone, or if you just need to talk to me, then I'm there for you, and create this shared responsibility. I'm responsible for my classmates or my co-residents or my colleagues' health, and they're responsible for mine. And I think that if we follow these steps, we will be a lot more likely to prevent suicide and prevent depression from taking more lives of residents, of physicians, and medical students. So that's what I wanted to talk about. And thank you again for inviting me. And at any point, if you have questions, or if I can help in any other way, I'm happy to do it.
Okay, thank you very much, Dr. Israel. It was really, really interesting. I think it's been really interesting for all the participants we have here. So we are going to have a space for questions. If I see that there are many people here who maybe might have maybe questions, because it was really interesting. So if you have any question, maybe this is the time to make them. So we're gonna wait maybe a little, some seconds for people so that they can just be able to write them down, and we can just read them out. Okay. So
I think we can start with a question of our own.
yeah, sure.
So I'm going to ask that because in IFMSA we work with a lot of medical students, and the medical students are the ones who want to make a difference. How do you think that what is the role that medical students can play in preventing suicide for physicians, or in creating an environment? And how much do you think institutions, for instance, medical teaching institutes for medical students and hospitals for physicians, are the ones that are liable or should be held liable or advocated to about this problem of burnout or suicide?
Well, thank you for the question. I think I wouldn't use the word liability because that puts a lot of burden in in the people who are maybe responsible, or maybe for the people who can actually do something about it. But I think medical students play a very important role in preventing suicides from their classmates. I mean, one way in which they can help is, they're there all the time. They see each other all the time, and they can tell when something is wrong. They can tell that something is different. So in a personal level, just the fact that you can go and say, hey, how can I help, and be available, and to be available to help, that's a huge step, and that can make huge difference in preventing suicide. And in another way, what you guys are doing, I mean, the medical students as an organization can get together and raise awareness for this. I mean, let the people who are going through this know that they're not alone, that this is something that's very common, that this is something that many students go through, and that this is something that we can do something about. In one way, in a personal level, to be available, in an institutional level, to raise awareness, and also to promote the creation of support groups among students, safe spaces where they can go and share their problems, share whatever is bothering them, and have an outlet for their frustrations, and they can say, hey, this is how I'm feeling, and that it may be a place where they know that they're not going to be judged, they're not going to be discriminated for that. That's something I think medical students as institutions can do. And then we have the response from the hospital itself, or the universities, or the program directors, which can also be very helpful by acting in a non-discriminative way, to let students and residents and physicians know that there will not be any consequences for saying, hey, I'm suffering from depression, or hey, I'm having these suicidal thoughts, that you're not going to be fired, that you're not going to be put on leave, that you're not going to be demoted or be given less cases than your partners, that you're going to be treated just as well. That's very that's very important, that becomes a policy for the institutions. And yeah, I think I think that's the most important thing that hospitals can do. And it's also in some places, residency programs can be really really stressful places, and sometimes just because the patients are difficult, or because it's a lot of work, but sometimes it's because there's a culture where it is believed that the younger residents or the younger physicians have to be punished, or they have to be mistreated in order that they can learn or become better doctors, because that's how I was raised. That's how it was when I was there, and you have to develop a thick skin, and that kind of nonsense. And to put in place policies that prevent people in authority to develop that kind of or to do that kind of mistreatment towards medical students or residents or physicians. I think that's something that can really help prevent burnout, and in preventing burnout, we can prevent depression and suicide. So I think that was a pretty long answer. I hope some of it was useful.
Thank you.
Okay, thank you very much, Dr. Israel. Here we have like some other questions from participants. There is a here we have Yilmaz Kambaru, who is asking about discriminated people like refugees or LGBTQ people. He's wondering how should we approach to these people to prevent their suicide.
That's a very interesting question, Jilmas. One of the challenges for physicians is to acquire competence to deal with gender awareness and multicultural approaches. From what I in our service, we don't really have a lot of people from different cultures, so I don't have personal experience dealing with people from with different who speak a different language, or people who went through a very different cultural or have a very different cultural background than mine. But I think there are some principles that we can all follow to make sure that we are helping in a constructive way. And one of them is being aware of the oppression. I mean, if we are in a position of privilege, we have to understand that, and we have to understand that life is harder for other people, and be kind and be empathetic, and take that into account. Take into account different values that different cultures have, and how things that may not affect us personally can affect other people. And I think being empathetic is something that it's very, 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 very important. And with the LGBTQ community, I think, well, I personally live in a country which is I live in Paraguay, and we are a very, very religious country, and sometimes that leads to a very discriminative attitude towards people from the LGBT community. So making them feel safe, and making them feel that they fit in, that doesn't matter what their sexual preferences or orientations are, I think that goes a long way in preventing suicide in this very, very vulnerable population. I mean, letting them know that they can be heterosexual or gay or whatever, or non-binary, or whatever they decide to be, and that they're not going to be discriminated against, not only by students but also by the institution itself. That goes a long way in taking that out of the equation, making them feel that they belong in the physician or in the medical community, and that we're going to treat them as brothers and as part of our community. I think that will go a long way in preventing suicide in this population.
Okay, thank you very much. And because of a matter of time, we're going to have just the last question, because we have many here. We have Iwese Giado. She's asking, okay, I would like to know what you would suggest to students from countries with a high stigma, like Nigeria, towards this topic should do to tackle this problem.
Well, raising awareness is the first thing that comes to mind, especially in the medical community. Showing evidence that this is not some first world problem. This is not some high society issue that is detached from the people with common everyday lives. That I think that's very that's very important, that we as physicians, in my case, or as medical students in your case, look at the evidence and speak from the evidence. And I think that helps destigmatize all psychiatric diseases. I mean, that's one thing I like to do when I talk to patients in the consulting room. I give examples about people who are dependent on metformin or losartan or enalapril. They have a disease and they have to take medicines for it. And it's the same with anxiety. It's the same with depression. I mean, this is a recognized disease. A lot of people suffer from it, and we have very, very effective ways of treating that, just like any other disease. And I think making them equal or similar to more organic diseases, I think that helps takes the stigma away. I mean, you wouldn't discriminate a doctor because he has diabetes or because he has hypertension. Why would you discriminate them because they have depression or anxiety? So I know the problem is a lot more complex than that, and I would probably have to do a lot more research to probably fully answer your question. But that's really what comes to mind and what I can tell you from my experience.
Okay, thank you very much.
Okay.
Just because we have like more questions than expected, we're going to move maybe these questions to the end of the webinar, because there are really interesting questions on here. So thank you very much, Dr. Israel, for your intervention. It was really, really, really fruitful, and I'm going to I know that you have maybe changed the mindset of many medical students around the world.
Hopefully so. Thank you very much for inviting me.
Thank you very much. So now we are moving to the next speaker, who is well, the third section of this webinar, which is we're going to see a little bit about what are the actions that the Federation is currently taking on approaching this topic. So we are going to have our IFMSA program coordinator on mental health. She's Ajesha Irfan. She's from IFMSA Pakistan, and she has well, an intervention to make today for us today. So I'm giving the floor to her. Thank you very much for being with us, and welcome.
Thank you for having me. First of all, hi everyone. I hope everyone can hear me clearly. So as for the impact of, I believe Dr. Israel has covered a lot of the points on hows and whys and everything. What I'm going to talk about is what IFMSA is doing on mental health at the moment. As for the program on mental health that IFMSA has, what we need to understand before we start analyzing the impact of IFMSA is that this year's program impact report has 44 activities from 32 NMOs. So which is triple the amount that we had last year. But for IFMSA, which has about over 130 NMOs, we still are lacking data from a lot, for like 3 times more the NMOs, to actually calculate the real impact that we have as a federation. But from the 44 activities that we did enroll this year, they came from 32 NMOs. And we all know what kind of activities happen, the division of activities. So most of the activities were education and awareness type. Like we talked about the 4 stages of how to prevent physician suicide, that pretty much applies to all the populations. So raising awareness and making it easier to talk about mental health and to talk about suicide and similar mental health problems is probably the first and most important step to actually preventing it. I believe that preventing suicide is um, more effective if we just prevent suicidal thoughts to begin with. But we're far from there, globally. I hope we will reach there at one point, but we're not there yet. So, as for the activities, we had most of the activities coming from Europe, and the second most were from Americas. Africa's had zero activities enrolled, which is quite unfortunate because that's the thing with mental health, that the places that need it most have um, the most stigma and like the most taboos around it, and they have the least amount of attention that is required there. So we do need to work more in Asia Pacific EMR, especially Africa's, on mental health. When it comes to the type of activities, um, so like I said, education and campaigning have been the most activities that have enrolled. Let me give you the stats for that. I'm sorry I couldn't prepare a presentation because I had a really, really tough week. Um, so education. So for campaigning, we had 19 activities with 153 events all over. In the 32 NMOs for education, we had 18 activities with 242 events all over. For advocacy and research, we had only one each activity and one each event. So clearly, we need to work on the advocacy part and research part of the suicide part. But again, like I said, I do believe there's a lot of research, like Dr. Israel told us as well. The sad part is that we are not really, calculating the impact. But I do believe there's still a lot of work that is still taking place, especially under IFMSA. But we don't get to see it in the mental health program. As talking more about the mental health program, we have a couple of outcomes, and they are number one, raised awareness regarding mental health within target populations. So, for that, our indicator is to increase the knowledge among the target population from pre and post survey. Again, like I said, we have discrepancy when it comes to collecting data from all these activities. So, we decided to calculate the impact on the outreach of all these activities. So we reached an overwhelming 406,647 people with these 44 activities, which is quite a lot. I think that has to do with the online campaigns, and social media has done a lot to increase the outreach of all the activities that we do. The second outcome we have is increased access to mental health services by medical students in need. I believe this is one of the very most important things we can do as a federation, because medical students have a very special place when it comes to mental health, because we are one of the vulnerable groups, like Dr. Israel told us, for stress, burnout, anxiety, depression. And at the same time, we are becoming future health professionals. So we can be the people who incorporate mental health into the primary healthcare, or like they said, every person who commits suicide has contact with the GP 1 month before. So we have that special place that if we are trained in a proper way, and if we talk about it in a proper way, then we can be in a place to change the status quo. The third outcome is to support, create, and promote mental health initiatives. And for that, there were 404 events from 33 NMOs, which again, like I said, is triple the amount from last year. But I believe the number is even larger than that. And the last one is engagement of stakeholders. This is probably one of the most important but least worked on outcome in IFMSA, especially in Asia Pacific and EMR region, because we don't really work on policies as much as we do on education and campaigning. But there was still one NMO that collaborated with their government and passed a policy on mental health. I wanted to especially talk about an activity that I heard about last year on, uh, was it last year? No, it was on this March meeting in Egypt. So we had a SCOMI and SCOPH joint session on mental health in medical students. And there was this, we were talking about different initiatives taken by different NMOs that promote mental health in medical students, not necessarily by IFMSA. So there was this student from Belgium who told that they had this system in their universities, which allocated 10 medical students to one doctor since the very first day of medical school. And they had these meetings every month in which they would just meet up and talk about how their month was, what were their struggles, and what good things they achieved, what help did they need. So I believe that plays a very important role. That you have such a connection with the person that you feel comfortable sharing with them any struggles that you have. When it comes to when these people are going through something stressful or are struggling with something or are feeling suicidal, I believe that this person that they're meeting every month um, can serve as a very important person that they can go to and who is also equipped to deal with this problem. This system was not specifically for mental health, but I believe that this could be one very good system that can be maybe made more specific for mental health and can work very well if incorporated in other countries as well. One similar thing that we are doing is that in our NMO, we had this unfortunate event that one of our students passed away. So after that, we created a mental health initiative, and it's a counseling program in which people who need help contact some people who are trained to deal with these people. And if they feel that they need professional help, they're referred to the psychiatry department. Other than that, we have art therapy, open mics, seminars, some fun fairs, and trainings to deal with these kind of situations. So there are very great initiatives going all over the world. For that, I recommend going through the activity database on ifmsa.org and looking for mental health initiatives. And you can contact the relevant activity coordinators if you plan on. You can feel free to contact me as well if you plan on conducting an event on that. So I believe that's all from my side. I'll give the floor back to you. Thank you so much for having me. I hope this helped.
Okay, thank you very much, Ajesha, for your intervention. It was really interesting to see how the IFMSA is actually well taking measures to approach the big topic of mental health. However, as you say, well, we need like a lot of more action, specifically on suicide prevention. Okay, so let's go with the next speaker.
So the next speakers actually will be Rico and Lindsay from BEMSA, Belgian Medical Students Association, and they will present their own initiative called Start to Talk project, which happened to be a great success in Belgium. And yeah, feel welcomed to their presentation. Rico, Lindsay.
Yeah, hello everyone. I think we have only one speaker because Lindsay just died. Well, her battery died. So for that, I will just do it on my own, I guess. So to start, Start Talk is actually a project we started only last year in Belgium, and we haven't enrolled it yet in IFMSA program database, but we'll be doing so soon. But we wanted to present it to you guys already because it's really just super nice for what you actually need. So how it actually started. So can I have the next slide, please? It actually started as just a workshop about 1 year ago. And the goal was just to brainstorm about an activity we could do. And for that, we had like a strict timeline agenda. We gave some facts about mental health. We did the confrontation game, like we did on the SCOPH meetings. We also had a testimony, which was just it was really groundbreaking actually, because it really got to people. It was like a story about someone who actually thought about suicide, and he actually tried to do it. Luckily, he failed because after that he searched for help and he actually found it, and now he's like a med student. He's like doing super well and like super super smart and all the rest. So it's really nice. But at that moment in time, he was really down and he really needed some help. Sorry. So that was actually really nice to hear at that moment. Hey, Lindsay.
Rico, yeah, I'm
Sorry.
here. I finally got through.
Do you
But
want to continue?
Yes, I heard you were doing very good. So it's true.
You can continue.
We had the testimony by a student that was, by all means of society, by all standards, high achieving. He was at the top of his class. He was very athletic. He had very, very many friends, but still he was severely depressed, and he thought about suicide, and he thought about taking his own life. He even planned out how he would take his life. But luckily, at the right time, he started talking about how he felt with professionals, and he found hope again. So after the testimony, did you already talk about the information and the confrontation game, Rico?
I did the confrontation game. I was about to start with the introduction round, actually. So
Yeah.
I really know.
But did you talk about that we first gave the information and in the confrontation game?
Not in detail.
Okay. So we actually had a structure. We started with some statistics, like that Belgium is amongst the top of suicide rates in Belgium, that 1 out of 5 students in Belgium is at risk for depression, which is a very high statistic. But we also wanted to bring those statistics into the room with us. And that's why we did a confrontation game. We asked the people to close their eyes so they wouldn't see who would answer positively with a yes or no, with the raise of hands meaning yes. They wouldn't know who would answer yes, but we would tell them which percentage of the room would answer positively to a question. We would start with a mildly confrontative question like, have you ever experienced exam stress? At least 90% of them said yes, of course. But we would go gradually to very confrontating questions like, who has ever thought of committing suicide? And still a very high percentage, like 2 out of 10, raised their hands. The group wouldn't know which one, but the statistic would be in the room all of the sudden. So that really put some thought in it, and the people started to feel those statistics entering. Then we did the testimony, which really opened people up too, because they were like, he seems so successful, he seems so socially experienced, but still that was a guy who really thought of committing suicide. And after that we started with an introduction round, so everybody could say what they were studying and who they were. And all of a sudden, in a group of strangers, people started to talk about things that are difficult to talk in our society. People started to say, I have OCD. I have to turn the lights off 8 times, or otherwise I have the feeling my family will die. And I was so amazed by it. It was so mind-blowing that just because of the structure of our workshop, people started to talk about those things. We know this was a subject that needed to be tackled, but all of a sudden, it started within our workshop, and it was so amazing to watch. So the people who participated in that workshop, many of those people are part of our Start to Talk team today, because they felt the effect of what such a group could do, of the effect of a group that was solely based on the premise that people started to talk about things that weren't going well. And there was no shame. There was just a high feeling of being connected with each other. And the people really felt relieved afterwards. So the next slide, yeah, we had the effect of the workshop. People started to listen to each other, which is as important as talking, of course, because talking without listening is like listening without talking. It's just useless and it's empty. Then after the workshop, we started brainstorming about what can we do? What can we do about this? But the answer already lied in our workshop. We just had to put that structure into monthly sessions and just let people come to us who wanted to talk about something, and let them know there was a safe space to talk about these subjects. And it was just as simple as that, because since then we've had 4 sessions, which isn't that much, but it was enough for us to see how important that was and how big the need for that was. Our sessions were always full, and with minimal promotion, people knew about us and came to us. Rico, can you go to the next slide, please?
I can control
Yeah,
this.
okay, Rico will take over. I don't know how much time I've left. I will try to stay though. And I also wanted to say I really appreciated the speakers before this. It was really interesting. So if I fall out, then you already know this.
Okay, thank you, Lindsay, very much.
You're welcome.
Okay, so now to the more practical part. So we actually start the project based on that workshop. So the main goal of it is actually really just a group of students who we gather, just a gathering with one person who is trained to actually lead the group, and just some simple, some easy, like basic communication skills, not really anything special. It's just like everyone can do it with, if you just want to actually. And we just use the same structure we did for the workshop. We activate them to talk, but we really focus on the fact that they should also listen and not give any solutions, because a mental health problem is not something you have like a problem and you have a method and it results in a solution. It's not the way it works. Just the fact that they can talk about is way more important than just giving a solution, because that doesn't work at all. So we try to reach as much students as we can. It's really for all students, not only the medical students. It's right now it's only one city in Belgium, but we try to expand it as much as possible. And also we try to focus on 2 groups, actually the native speakers and also the international students, because we feel that we can't really put them together, because language is really a big barrier to talk about the problem actually. If you put some native speakers into an English talking group, it's really hard. It doesn't work. And the other way around, if the international speakers can't really speak Dutch well enough, or the other native language, then it also doesn't work. But because of the practical reasons, we also do registrations. Really sorry for this evening. I'm really not articulating well. But it's really just something we have to do, the registrations. It's too bad actually, because we want to make it open for everyone, but for practical purpose, we have to know how many people will come. And based on that, we try to form groups of 10 people, because if you have groups that are too big, then it doesn't, then people just become silent. If you have groups that are too small, the same happens. Just about 10 people is really just a nice amount to let people talk actually. It's really nice. So then for the structure, we already said that part in the origin, so I will skip that to, and we'll go to the next slides, please. Okay, so another part of the project is to actually make promotion, because we have a workshop, but we also have to promote it, which is actually really hard, because we can just make a Facebook event for it. If we do that, then people just won't come. They won't just say, hey, like, I'm going to a mental health session. I'm just going to say all my problems. No, unfortunately, it doesn't work that way. That's why also we have the anonymous registrations, so people don't know who will come. And we also try not to focus only on on promotion, but also inform people what the project is about. So create awareness in a way by just promoting the project. We don't know what impact it has, but we think that alone can really just activate people to talk about the problem. Also, we have a cooperation with the student psychologists. For people who don't know what that are actually just psychologists associated with the university, where students can come to without charge, so fully free. And we also work together with local NGOs to promote the project, but also have a location which is not linked to anything, not linked to the university, not linked to any organization at all, actually, which you think also decreases the barrier. Then also both the student psychologists and the local NGOs also form a referral point for people who need more help than just a group of students who talk about their problems. Some people you can't just help with talking, they actually need a psychologist. So that's where they come in. So we really have a tight cooperation with them. But also for moderators themselves, sorry. Because let's say you have a student who came to the session, he talks about suicide, and after that he leaves. A week after that he actually commits suicide, and then you can actually think oh no, I didn't do enough, I didn't help him enough. So it can really be a big burden, I think, on the moderators, which is too bad that it's that much of a burden, but it's also important that they are involved, because that's decreases actually the barrier to talk about it. So for that, we have also have the student psychologist as a referral point to actually let the moderators seek help if they need it, should they need it. And then for the next slides, I think that's our future vision. Yeah. So what are our goals for this project? First of all, we want to enroll it in the mental health program and to actually promote it to everyone, because we really want everyone to convince everyone to actually start it themselves. It doesn't cost anything. You just need a location. You don't need much of resources, just people. It's really easy, and you can have a really big impact. And also, we are focusing secondly on our moderators. We think they need more skills, better skills to actually lead sessions. So that was it for the introduction of our project. I hope everything is clear. I'm not really well structured sometimes. Not in this chaos.
That's okay.
Well, thank you very much, Rico and Lindsay. It was really amazing to hear about your project, and I don't think it's not structures at all, Rico. As you can see, with a simple idea to talk about the mental health in some specific manner, we can actually make an impact on people's lives. And that's, I think, the take-home message from the project that the BEMSA has done in their NMO. And it's amazing how you can see that even the students, the medical students, can do something about the suicide, right? Or in general, the mental health. We should really look after each other, and we should really be able to provide the psychological help to the people that may face some difficulties, face some mental health burden. So now we'll proceed to the questions that our participants ask on the YouTube in form of the comments or in the Facebook. So first question, let me just find it. So I believe the question by Mustafa Nasser from Egypt, it was the question for Dr. Israel. is our role for advocating and having a common ground with the stakeholders, or there are further steps that we also can help?
Hi. So yeah, I think I talked about this a little bit. I think the most important thing that we can do is actually look for a common ground with the stakeholders. I mean, just simply be, as I said before, be available, be willing to ask questions. If you see something, say something. But no, I don't think that that's the only thing that we can do. As I said before, I mean, if you have an organization or an organization such as this one, I mean, you can do this. I mean, you can raise awareness. You can get people the information they need so that they don't act in a discriminative way and in a way that they can be supportive. So yeah, I mean, I don't think I think that's the most important thing that we can do, is be available and be willing to ask questions. But I don't think that's the only thing that we can do.
Maciek, you're muted.
Okay, yes.
Sorry. Thank you very much, Dr. Israel. Our next question is also to Dr. Israel from US Gado. I hope I spelled it correctly. So, good evening. I would like to know what would you suggest to students from countries with high stigma towards the topic? How to tackle the problem?
Yeah.
I think this is a repeated question. I mean, I've already answered this. I mean, again, it's I don't have enough experience in this area to talk very confidently, but I would believe as medical students, science is our friend here. I mean, being able to show that this is a disease just like any other, and that it doesn't imply that you have to be discriminated against, or that you have that you are less than someone else just for having it. I think that would go a long way in destigmatizing depression and anxiety and burnout and everything, and all these conditions that can lead to suicide.
Okay, so we have another question here from Raúl Vallejos. He asks, how important do you consider treating or detecting these cases at the primary attention?
I'm sorry, Juan Sebastian, is that a question for me?
Yes.
Oh, yeah. I think it's well. I think a primary care is of utmost importance in detecting depression. I just don't think for physicians, I don't think that's a place where they will go for help. So I think we will have to be a lot more proactive than expecting them to go to a primary care physician to deal with it. Now, if we talk about the general population, yes, and yes. I mean, primary care physicians are the first step and the first point of contact with the healthcare system. And yes, we can do a lot in primary care, in the primary care services to prevent depression. The Columbia scale. Let me look it up just really quick. Columbia suicide. There's a website that you guys can check. There's a project called the Lighthouse Project. They developed a Columbia scale of suicide severity to identify risk and prevent suicide. And they are going a step they're going a step further and they are administering a very short scale, very easy to implement. They're doing it not just in primary care services, but they're doing it in schools. They're doing it in churches. They're doing it in workplaces. They're doing it everywhere, and they are seeing in the VA system in the United States, they're seeing a 50% decrease in suicidality or in suicide cases, and they're having this amazing results. So I would suggest that you guys check this website out. I'm gonna put the link there, so maybe you can share it with the audience in YouTube or Facebook. They are doing an amazing job in suicide prevention. They have training seminars they're available for free. They have translated this scale in many different languages. They have validated them in many different languages and settings. So again, yes, I mean, primary care service, primary care healthcare is, I think, the one of the most important places where we can start preventing suicide. Just not, I just don't think that's a place for physicians to where physicians will go. But for the general population, yes, definitely.
Okay, thank you very much for answering to this question. I will share the link among the participants on the Facebook event and also in the Facebook, in the YouTube. So there's the last question we have. So what can we do at the first place to increase our mental resilience? So like mental capacities to deal with normal life, with stressing events in general. And this question is to Dr. Israel as well.
Well, there is an amazing study. It's called the Adult. I mean, I'll share the link again. The Adult Development Study. There it is. It is one of the largest study in the history of science. Actually, I think they started back in 1975, and here we go. This is another website that you can share maybe with the people on YouTube or Facebook. This is an incredible study done in the Harvard University, and they followed people from their time in the university until they were 85 or 95, and they're still going on with this study. And they found that the most helpful thing that you can do for your mental health is developing strong relationships. So that's if you have to invest in something in your life, and it is an investment because it's hard to maintain good relationships. I mean, you have to be willing to be vulnerable. You have to be willing to take initiative. You have to be willing to spend time on them. But if there's something that you can do to increase your mental health, which has definitely positive results, not just in the next hour or the next a year or even in the next decade, but for your whole life, is to develop strong relationships if you are able to do so. In a more personal level, I mean, in a more immediate way. I mean, if you're struggling, seek help. I mean, if you're having suicidal thoughts, if you're feeling down in the dumps, if you're feeling the blues, if you don't want to get up in the morning anymore, if you don't find a reason to live anymore, go look for help. Go to a psychologist, go to a psychiatrist, talk to friends who you trust, and you will. If you go to a mental health provider, you will definitely find the help that you need. And if you're not there yet, I mean, if you just if you say, okay, I'm just getting into medical school and this is what's in for me, I want to build a resilience, then probably meditation is one of your best options. Mindfulness has proven to be great at reducing the rate of depression and anxiety in the general population. There are very easy ways in which you can do it. There are apps for your phone, apps like Calm or Headspace that are scientifically proven to work, and you can download those. Some of them are available for free. Some of them you have to pay for them, but you will definitely see good results with them. But in the long term, just again, building stronger relationships is your best bet to develop a great mental health in the long term.
Thank you very much. I've also heard that building the strong relationships is one of the most prolonging our life factors. So we should really focus on that during our lives. Another question is, what is your opinion on cognitive therapies, such as a rational emotive cognitive therapy? Should we really focus on that, or we should rather implement mindfulness or meditation in our, let's say, resilience exercises? It's a question to Dr. Israel. Yeah.
Oh, okay. Well, I love CBT. I love cognitive behavioral therapy. I'm actually training for it right now, so it's great. I mean, it's scientifically proven. It works, but it's usually used in people who suffer, who are already suffering from depression or have depressive symptoms. It's extremely effective for mild or moderate depression and anxiety. Is the first line of treatment. It's just as effective as fluoxetine or sertraline or paroxetine. So it's really great. I mean, we don't have that much evidence for mindfulness, or what we call the third wave treatments for depression and anxiety. We know that they work. We don't know if they work just as well as CBT for treating disorders such as anxiety or depression. But we do have evidence that they help build resilience. They're easier to do than a CBT program. You don't really need a psychologist to guide you. You don't really have to go anywhere. You can do it at home. It's very easy. It's very simple. It's effective. So if you have the opportunity to do that, then yes. I mean, for building resilience and for mental health prevention, I think that's one of the best ways to do it. But CBT it's probably more for treatment. If you're already depressed, if you're already suffering from generalized anxiety disorder or panic disorder, then I would suggest that you absolutely go for CBT.
Okay, thank you very much.
Yeah,
Dr. Israel, for your intervention and for all the answers to all the many questions that participants had. Just to wrap up, well, I just want to say thank you very much to all the participants who were just stick to the webinar during the whole time, and also to our speakers. Thank you very much to Rico, to Lindsay, to Ajesha, Dr. Israel, and Nishwa and Maciek for this. I think it's really important to have these spaces just to start talking about these topics that maybe for in a lot of countries it is maybe forbidden people are not so open to talk about it. So I think it's really, I consider these spaces really fruitful. So that is why, as we see, like there's a lot to do, but I think that the first step is just to gain awareness about this and really believe that this is an issue that needs to be tackled, and well, start working on that. As Americas region, we are currently working within the Federation on small working groups, creating projects that will maybe be spread out to many countries to start working on mental health. Also, we have been working on trainings and capacity building to work on mental health, because we truly believe that there are high rates of suicide, people attempting suicide, and it's something that can be prevented. So yeah, thank you very much to everyone, and well, I really enjoyed the webinar.
Yes, I want to also add that one of the European priorities this year in SCOPH is also mental health, and we recognize the increased need to work on this topic, basically because it's largely avoided and underestimated topic. We usually do not consider our mental health equally important as our physical health, and the same is within the society. People usually know how to care about the physical health, what are the general principles, but if it comes to the mental health, we are lacking of a very strong evidence-based information about it, and the same is within the society. Shfa?
Okay, so I'll finally wrap up the whole webinar. I really, really want to thank all the speakers that we have, Dr. Israel, Aisha, Rico, and Machik and Juanse for organizing this all. At the end, I would just like to say that just some points from the webinar, that firstly, it does start from yourself always. You're medical students. We are a vulnerable group inherently. And secondly, even if you're working at FMSA, when you have a very crazy time schedule, that makes you more vulnerable as well. And secondly, I really like what Dr. Isabel talked about. Two things. Firstly, that there are things that you can do in your everyday life, meditation, etc. So be mindful of your own mental health, and then evidence-based. So for anyone who wants to help someone, who wants to create a change, start with research, read up on everything, evidence-based projects, and reading up is the first thing that you should be doing, which leads to effective projects. And you can only have smart designs of projects after you know what the problem is, and after you know the inherent links and the cause and the ends meet, so you can actually focus on the causes. Lastly, if you ever need any help regarding activity management, regarding evaluation, etc., and anything, please approach our program coordinator on mental health, and please enroll your activities. If you need any help regarding resources in general, you want to discuss what other NMOs are doing, please reach out to your RAs. So just good luck to all of you with your projects and whatever you're doing. Take care of yourselves. Dr. Isla, would you like to say anything at the end? And then we can go. Would you like to say anything? Anyone, Rico,
Yeah.
Anyone?
Thank you very much again for inviting me. It's always an honor to be a part of your activities, and thank you so much for raising awareness about mental health issues. There's a lot of stigma around this. There's a lot of silence around this, and just the fact that you are talking about it and raising awareness, I think that's extremely positive. And even starting this amazing evidence-based project, I think you're gonna make a great change in preventing suicide. So I want to congratulate you for that, and I'm always available if I can help in any way.
We'll definitely reach out to you for that. Thank you very, very much, everyone, for being a part of this webinar, for asking questions. We are really looking forward to your activities, to your questions, to your interests. Be in SCOPH around, and look forward to the resources that Machik and Juanse have. on mental health as a usual priority, and bye-bye from all of us.